Hi, I'm Devin.
And I'm Tanner.
And this is What You Need to Know.
What you need to know, what you need to know about GLP-1s.
So GLP-1s, or glucagon-like peptide receptor 1 agonists, are a medication class used at multiple points during the progression of type 2 diabetes. There are currently 7 medications approved in the United States. 6 of these medications are injected subcutaneously, and there is only 1 oral agent.
So of the 6 injectables, there are 2 short-acting agents, exenatide, brand name Byetta, that is dosed twice daily, and lixisenatide, brand name Adlyxin, that is dosed once a day.
So there is also 1 intermediate, and it is called liraglutide, better well known as Victoza, and it is also dosed once a day.
There are 3 long-acting agents that can be dosed once a week. They are Bydureon, Trulicity, and Ozempic, which is semaglutide. The 1 oral agent that is available is also semaglutide with the brand name of Rybelsus.
This is just a brief overview of the GLP-1 agonists and their dosing. We will go into further detail later in this video.
Typically, after ingestion of food, the small intestine releases incretins like GLP-1 that then stimulate the pancreas to secrete insulin. The GLP-1 receptor agonists work by mimicking what GLP-1 does in the body.
So in summary, GLP-1s work by 1. Stimulating insulin secretion from the pancreas in a glucose-dependent manner, and 2. During times of hyperglycemia, they reduce the amount of glucagon secreted from the alpha cells in the pancreas in order to decrease hepatic glucose production. They also slow down gastric emptying. In the brain, they work to increase satiety, so this leads to patients feeling fuller faster and can lead to weight loss.
GLP-1s aren't considered first-line therapy when treating diabetes, but they're the perfect add-ons. They are considered highly effective at decreasing A1C with an estimated decrease of about 1%. Of course, since they're add-ons to therapy, A1C drop depends on numerous factors, such as the patient's current glycemic control, their background therapy, and specific agents used.
The most common side effects that patients can expect from these medications are, can I get a drum roll, please? You guessed it, it's nausea and vomiting, which can occur in about 20 to 50% of patients. This is because they slow gastric emptying, and this may also contribute to patients having either diarrhea or constipation.
Now, nausea and vomiting at 50% is kind of a lot, right? So how do we minimize the amount of GI side effects that our patients experience? The good news is that there's a couple ways we can help. One very important method we utilize is a slow titration schedule with these agents. The dose should be escalated as the patient can tolerate every 1 to 4 weeks. Now, the exact titration schedule depends on the specific agents that we will get to later in the video.
So in combination with the titration schedule, informing the patient that they will not be able to eat the same amount of food as they used to can help reduce the incidence of nausea. Because one of the mechanisms, as we discussed earlier with GLP-1s, is that they slow gastric emptying. So overeating actually leads to significant nausea. Counseling the patient on this can actually save them a lot of discomfort in the end.
So on the other hand, side effects of GLP-1 agonists such as decreased appetite, increased satiety, and weight loss can be favorable in some patients who are overweight or obese with a goal of decreasing their BMI.
So one more thing I'd like to mention is that although hypoglycemia is listed as a warning for all of these GLP-1s, the incidence is rather low, and it's not really a big concern for this class of medication. Everybody likes a good recipe, right? Well, we're going to show you what makes for a really bad recipe with GLP-1s. So stay tuned here on Tanner's 30-Minute Meals.
Tanner's 30-minute meals, yeah, 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 yeah. Tanner's 30-minute meals.
Like with any other medications, you want to make sure that there's no contraindications before prescribing these agents to your patients. An easy way to remember this for GLP-1s is the acronym PGMART. So let's go shopping. Ain't nothing like mama's cooking.
Welcome to PG Mart. Please make sure to maintain 6 feet between other customers, and for God's sake, please wear your mask at all times.
All right, Devin, looks like we got to go to aisle 7 for our first item.
All right, let's head over.
All right, man, looks like I found it. It's the P. P is for pancreatitis. Since this medicine works primarily in the pancreas, they are not used in patients with a history of or active pancreatitis.
All right, now that we got the P, I think our next ingredient's right over there. Found the G. G is for Gizmo!
No pets allowed in the store.
I think you are sadly mistaken. That is the wrong item.
Oh yeah, my B. Here's the G we need. G is for gastroparesis. These medications also increase satiety by slowing down gastric emptying, otherwise known as gastroparesis. Therefore, they are contraindicated in patients that have known gastroparesis.
Dude, Devin, check it out. I got a coupon for M.
Oh, nice, dude.
M is for multiple endocrine neoplasia type 2, commonly known as MENS 2. This is also contraindicated in GLP-1s.
Hey, did you pay for that?
Hey, what did you get into now?
It's an apple for A.
No, Devin. A is for allergy. As with all medications, hypersensitivity is a concern. An important emphasis I would like to make is that a history of angioedema is also a contraindication for the use of exenatide, liraglutide, and lexacenatide, but it is not noted with the other agents.
All right, Tanner, I'm gonna head to the fridge to get the R. Red Bull, I need them wings.
Get the case, Devin. We're gonna need them for those all-nighters studying on rotation.
No, but seriously, R is for renal. Now, keep in mind that different GLP-1 agonists have different GFR cutoffs for their use. Although some of these medications have not been extensively studied with regard to renal function, we do know that the exenatide formulations, both Byetta and Bydureon, should be avoided with a GFR of less than 30. Adlyxin, or lexacenatide, should be avoided with the GFR of less than 15. Due to the uncertainty about renal impairment, monitoring the patient's renal function is warranted.
All right, the next item is T. T is for toilet paper, you know, for the pandemic.
Only 2 rolls per customer.
Tanner, I told you to stop hoarding the TP, man. Other people need it too.
You're right, Devin. The Charmin can wait. T is for thyroid cancer. Specifically, these medications are contraindicated in patients with a history of medullary thyroid cancer.
All right, Tanner, I think we got everything.
It's kind of busy in here. Let's go check out at the 10 items or less register.
Thanks for shopping at PG Mart. We do not appreciate your business. Please do not return.
So now we're going to cover the dosing of the individual GLP-1 agonist. Byetta is the immediate release formulation of exenatide. It's dosed twice daily, 30 minutes to 1 hour before a meal. To minimize side effects of nausea and vomiting, it is appropriate to have the patient inject themselves closer to mealtime.
For example, if the patient is expressing concern about the side effects, have the patient inject 30 to 45 minutes before their meal. This will help relieve some of the side effects. But the closer the dose is to the meal, the less effective it becomes. Also, this formulation can stay at room temperature away from direct light for up to 4 weeks.
So as mentioned before, a slow titration is recommended when dosing this class of medications. After 4 weeks of the twice daily 5 microgram dose of Byetta, it is increased to 10 micrograms twice daily. If a patient eats multiple meals a day, then counsel them to use Byetta on their 2 biggest meals of the day. Since the medication is dosed before meals, counsel the patient that if they forget to take it before their meal, just skip the dose and resume at the next scheduled dose before that meal.
Byetta is the least convenient GLP-1 because of the dosing regimen. And compared to the others in the class, it seems to have a higher incidence of nausea and vomiting, as well as injection site reactions. It kind of may seem that we're picking on the old guy, but Byetta was the first GLP-1 injectable developed, so cut him some slack.
Now we saved a major point for last, and that is that Byetta does not come with the pen needles for injection. Please inform the patient of this and write a separate prescription for the needles.
Bydureon is also exenatide, but it is the extended release formulation. Think of it like Byetta being the 1995 Chevy Impala. and Bydureon being the 2020 Corvette. Both will get you from point A to point B, but which car would you rather drive?
Bydureon is dosed 2 milligrams subcutaneously once weekly without regards to meals. If the patient happens to forget to take their regular dose, inform them that as long as there is at least 3 days before the next scheduled dose, then they can go ahead and inject themselves. If by chance the next dose is less than 3 days, then skip it and resume administration at the next scheduled dose. Bydureon is available as Bydureon Pen and Bydureon B-Size Pen.
So both of these products require assembly and mixing in order to ensure that the full dose of the medication is given. However, differences do exist between the two products. For example, Bydureon Pen is supplied with pen needles separately that require attachment before injection, while the B-Size comes with the needle already built into the device. In our personal opinion, the friendliest product out of these two is going to be the Bydureon B-Size. There are less steps to remember for the patient, and the needle is already attached for safety reasons. Exenatide XR can also...
Tanner, what is that?
It's actually not that serious, Devin. As I was saying, Exenatide XR can also cause injection site nodules, likely due to its formulation. It is encapsulated in microspheres made of biodegradable polymers, which release the drug over a sustained time interval. This point would be important to mention to the patient so that they are not freaked out about hard nodules in their abdomen.
Like I was.
This formulation can also stay at room temperature away from direct light for up to 4 weeks.
Ozempic, or semaglutide, is dosed 0.25 milligrams once weekly for 4 weeks. It's then increased to 0.5 milligrams once weekly. There is the option to increase again to 1 milligram after 4 additional weeks if needed to achieve glycemic goals. The intention of the 0.25 milligram dose is to reduce GI symptoms and increase the patient's tolerability.
So if a patient forgets to administer their weekly dose on their scheduled day, and it has been less than 5 days, the dose can be given. Otherwise, skip the missed dose and resume at the next scheduled administration.
All right, so now we're on to our next...
You hear that?
New drug. New drug I learned. New drug I learned.
Well, kinda. In 2019, Rybelsus, or semaglutide, became the first approved oral GLP-1 agonist, and it's currently the only one available on the market. Okay, so an oral drug in a class of nothing but injectables. Let's get our patients started on it, right? Well, it's not that straightforward. Because the absorption of semaglutide predominantly occurs in the stomach, it has more complicated instructions on how to take it. Not taking Rybelsus exactly as directed will render the drug much less effective. But before we go into detail about the instructions, let's go through the dosing.
With Rybelsus, we start with 3 milligrams once daily for 30 days. After 30 days on the 3 milligram tablet, we increase the dose to 7 milligrams once a day. The dose may be increased to 14 milligrams once daily if additional glycemic control is needed, after at least 30 days on the 7 milligram dose.
Okay, so now for the details on counseling a patient on how to take it. It's important to take it at least 30 minutes in the morning before ingesting anything. That includes first food, beverages, or any other oral medications. Also, it should be taken with no more than 4 ounces of plain water.
That's not much.
No, it's not. Also, waiting less than 30 minutes to eat after taking the medication will lessen the effect of Rybelsus. So it's important to wait at least 30 minutes to eat after taking the medication as well.
So you can probably see that these directions are not the easiest to follow for patients, especially when compared to the GLP-1s that are dosed once weekly without regard to food. That being said, if your patient is scared of needles, this may be an option to consider.
Trulicity, or dulaglutide, is dosed at 0.75 milligrams once weekly. This may be increased to 1.5 milligrams once weekly after at least 4 weeks if the patient is tolerating it. Again, the starting dose is likely not as effective for glucose control compared to the 1.5 milligram dose, but the main concern is patient tolerability. Trulicity comes as a ready-to-use pen, and if needed, it can be kept at room temperature for a total of 14 days.
As you can probably see, there are a couple of reasons Trulicity is a preferred GLP-1. Number 1, it's dosed once weekly. This helps with improving patient adherence. Number 2, the pen comes ready to use. It has a needle already attached for safety reasons. And number 3, when teaching the patient, it's a 3-step process. Uncap the pen, place and unlock, press and hold. It's as easy as that.
Adlyxin, or lixisenatide, is dosed at 10 micrograms subcutaneously once daily, 1 hour before breakfast for 14 days. And then on day 15, we increase it to 20 micrograms once daily, 1 hour before breakfast as well. If the patient misses their dose, instruct them to administer within 1 hour of the next meal and to not double up on the dose.
So prior to initial use, this medication should be kept in the refrigerator. Once being used, though, this medicine can be stored at room temperature and the pen is good for up to 14 days.
Victoza, or liraglutide, is dosed once a day and has a starting dose of 0.6 milligrams. It is an important counseling point to mention that the starting dose is likely not very effective for glucose control. Its main purpose that it serves is to help the patient with tolerability. This includes minimizing nausea and vomiting. So, after 1 week of the 0.6 milligram dose, the dose is then increased to 1.2 milligrams once a day for 1 week. If the patient continues to tolerate this 1.2 milligram dose after 1 week, then the dose is then increased to 1.8 milligrams, which is the final dose of Victoza once a day.
If, however, the patient cannot tolerate going from 0.6 milligrams to the 1.2 milligrams in dose due to the side effects, then it is actually recommended to have the patient alternate between the 0.6 milligrams every other day with the 1.2 milligrams every other day until the patient can actually build tolerance to the 1.2 milligram dose. The same steps can be taken when the patient is being increased from 1.2 to 1.8 milligrams.
Another important point that I would like to make is that Victoza is another GLP-1 that does not come with the pen needles for injection. These needles must be prescribed separately for the patient to use Victoza. Also, since the medication is once daily, if the patient happens to forget their Victoza for more than 3 days, then a retitration schedule is necessary.
So for some additional information, the LEADER trial showed that liraglutide significantly reduced the risk of cardiovascular death, non-fatal MI, and non-fatal stroke by 17% compared to placebo in patients with type 2 diabetes at a high risk for cardiovascular events. Liraglutide also reduced all-cause mortality and slowed the progression of renal disease. With these clinical results, liraglutide was able to get FDA approval to reduce the risk of major cardiovascular events in adults with type 2 diabetes who have established cardiovascular disease. There are other trials out there that have shown that GLP-1s help reduce the risk of cardiovascular-related events, but Victoza is currently the only one FDA approved for this.
It's wrap-up time. We discussed a lot of things, and I know it was a lot to take in. But here are a couple helpful tables of the drugs we discussed. Feel free to pause the video, or even better, you know we like free things, the link's in the description down below. And you can download all the tables that we provided for you.
So here's some things to consider for your patient. Please keep in mind that these medications are expensive, ranging from $500 to $1,000 cash price. It is important to be familiar with the patient's insurance plan, as this will determine whether the prescription is covered or not. Another resource that can be used to assist patients is the website of each product that you are prescribing. There are actually videos of how to use this product as well as copay cards for commercial plans to assist the patient as long as they meet the requirements.
So let's cover some highlights. Number 1, GLP-1s are great add-on therapies for patients with type 2 diabetes.
Number 2, remember the acronym PGMART for contraindications.
Number 3, GLP-1s come with beneficial effects like weight loss, and liraglutide is also cardioprotective.
Number 4, GLP-1s commonly cause nausea and vomiting, but a titration schedule and providing helpful tips for the patient can reduce this.
Number 5. Each GLP-1 comes in various doses, and the devices are different as well. Using your resources and providing your patient with additional resources can ensure that they get the maximum benefit from this medication.
Until next time, this is
What you need to know.
What you need.